Great, thank you. Thank you very much. For those who don't know me, my name is Michael Anderson. I'm CEO of MedAccess, and it is a really great pleasure to welcome you tonight. I'm very grateful to each and every one of you for making time to come share the evening with us. I do think it's a really interesting conversation we have in store this evening, so I think you'll be rewarded richly for that. I do also know that some people need to leave early, and there are escape hatches out both of those corners in which you can get away at the appropriate moment. Tonight is a little bit of a hybrid event. We are celebrating 5 years of MedAccess existing, so it's our birthday. We want to celebrate. But we also wanted to have a serious discussion about how is the world going to approach providing access to vaccines and medicines in a really rapidly changing global landscape with lots of challenges. Because while MedAccess is wonderful, and I'm extraordinarily proud of some of the things that we've done, the size of the problem is absolutely enormous, and we are nowhere near resolving all of it or addressing all of it. So tonight, I hope, is a chance to address some of those. We framed this evening in terms of we're living in uncertain times, really uncertain geopolitical times, very uncertain economic times, and the world has experienced a kind of health shock of the kind that it just has not experienced in such breadth and intensity for decades and decades. So a lot of uncertainty about future approaches to health as well, and that's the setting for this evening. However, the introduction is going to be done by the Right Honorable Andrew Mitchell, MP, who's the Minister of State for International Development. Andrew actually accepted the invitation to come to this event before he was appointed minister. And then his office said, well, now you're minister, we actually want you to go travel to a dangerous place rather than going to this reception. But he has very kindly agreed to record some messages. He's been a long-standing friend of this topic, long-standing friend of Gavi, and a supporter of MedAccess. So we're going to hear from him on video. I just give you a word of warning, which is Andrew was in the Territorial Army, and when he pronounces, he declaims. So fasten your seatbelt for the first 10 seconds or so. Andrew, please.
Friends, colleagues, since it was established just 5 years ago, MedAccess has had an outsized impact. Its innovative financing model has unlocked access for at least 8 game-changing health products that are reaching hundreds of thousands of people and helping to save lives in more than 90 countries. The UK has been a supporter from the start. MedAccess was founded with a $200 million investment from the UK's development finance institution, British Investment International, which aims to overcome development challenges with the power of innovation and the private sector. MedAccess is a prime example of that in action. By reducing market risk, MedAccess's financial guarantees increase the reach of new health products while also creating demand that grows the market. The transformative impacts speak for themselves. For example, by using a volume guarantee to secure a 30% reduction in the price of dual HIV syphilis tests, MedAccess has brought the price much closer to that of single HIV tests, which is expected to help an extra 4.5 million pregnant women and their babies by enabling them to receive the treatment they need and averting preventable deaths from congenital syphilis. The value for industry is also strong. For example, MedAccess's agreement with manufacturer BASF enabled them to increase production of their next generation malaria bed nets. These nets were developed with UK R&D expertise through our investment in the Innovative Vector Control Consortium. The partnership has already averted 1.5 million additional cases of malaria, showing innovative finance can combine with scientific excellence to save lives. But reaching people with new innovations like these relies on governments and procurers, such as the Global Fund, to deliver products at scale. The UK's £1,000 million commitment to the Global Fund's next replenishment will contribute to saving well over 1 million lives. And it is clear that MedAccess can make this funding go even further by securing lower prices for health products and ensuring that quality supply is available. This year, the UK set out our approach to strengthening global health in our international development strategy. As part of that, we will continue to work with MedAccess and support the innovations and research needed to save and improve lives around the world.
Thank you, Andrew. So we are really deeply grateful to the Foreign Commonwealth Development Office and also British International Investment. British International Investment founded MedAccess, and we've had very extensive support from the FCDO. I do want to, it's divisive to name names, but I would like to name out 3 people from British International Investment: Holger Rotenbusch, who's here with us tonight, Nikhil Chulani, and Setor Lassi, who've all just been with us throughout this long journey. And on the Foreign Commonwealth Development Office, particularly Sarah Bolton, Sarah Davaj, and the ghostly figure of James Droop, who I noticed just sneaked in the corner there, who actually conceived of the idea of MedAccess when he was an official at the FCDO, DFID as it was then. But we were founded on the proposition of having a different approach to addressing the problem of access to medicines. From the patient's perspective, around the world, the problem is just staggering. We've become inured to the problem of people not having the health products they need. By contrast with the UK last year, we had a shortage of HRT supplies of a particular kind, and it made the national press. Downing Street was making announcements, comments. There was a global national response to the problem. Similarly, in the United States, last year, there was a shortage of infant formula, and the government invoked the Defense Production Act to make sure that manufacturing capacity was diverted to help fill that gap. So when there are specific gaps in supply in high-income countries, it becomes a matter of national attention and political response. Meanwhile, in, say, a maternity ward I visited in Gambia some 25 years ago, there were just beds. There was nothing else. I mean, there weren't even really very many blankets. Now, that was a long time ago, but the lack of access to any kinds of supplies or oxygen or medicines or help with delivery was just kind of taken for granted. It was what was there. And part of the reason MedAccess exists is we want to question that kind of taken for grantedness. So that's part of the reason we were founded. There are, according to the WHO, some 2 billion people who lack access to essential medicines, and we would like to help use finance to help address that problem. We do live in a world where we've had a really strong focus on COVID, and COVID-19 did show us that the world is divided, especially on vaccines for a chunk of time, into the haves and have-nots. And we've learned a lot from that. We're going to build on that. A lot of innovation, which has been terrific. Sir Graham, welcome. And although that kind of COVID-19 moment really defines what we need to address immediately, there's a much more ordinary, everyday lack of access to medicines. You know, very taken with the everyday sexism movement, identifying the way in which sexism occurs in all kinds of interactions. There is a kind of everyday lack of access to medicines which occurs and just taken for granted. And we feel that we are in a good place to help address some of that. We do that by providing finance to bridge the gap between makers and buyers. We partner with businesses to help them de-risk bringing their products to market. In finance terms, for those of you who are finance fans, we occupy an unusual place because while there's lots of equity and debt to invest in new manufacturing capacity, to invest in new, shorter supply chains and so on. There's very little, on the supply side, there's plenty of finance. On the demand side, helping to de-risk, what do I do with my offtake once I manufacture something? There's very little provision on that side. And MedAccess is trying to help fill that place to bring some balance into the supply and demand finance. So over the last 5 years, we've had the good fortune of having some terrific partnerships, and the partnerships have allowed us to help deploy our single tool in a powerful way, but within an ecosystem that makes the difference. Partners, the global institutions, manufacturers, civil society, regulatory bodies, innovators, NGOs. And we have, over that time, completed 9 guarantees. Looking to the future, we'd like to build on that success. We feel like when we were first founded, it was a bit of an experiment. We weren't sure that we're going to be able to do this, to be honest. I think we're now in the place that we've discovered that we can do it. And there's a really big range of possibilities out there. In investor terms, our pipeline is sort of bulging, and there are many, many things we could take on. We just don't have the staff time to do at the moment. And that's very promising because we think it's a powerful tool. We'd like to do that because we would like to shape a healthier world, and we're committed to partners in this room and elsewhere to help bring about those changes in a sustainable way. So you don't want to hear any more from me because we have a panel, but before we move to the panel, we have a short video to describe a little bit about what MedAccess is about. And then I'll invite Helen Rees to chair the panel. But Andrew, can we see the video?
We live in a golden age of medical science, but over 2 billion people can't access the medicines they need, causing preventable illness, disease, and death. Health markets are broken, leading to a gulf between makers and buyers that isn't yet bridged. We are here to change that. Since 2017, we have brokered 9 agreements, partnering with organizations across the health ecosystem to speed up access to modern diagnostics and tests, to innovations that are tackling malaria, to new treatments for TB, and in the COVID-19 response. We do things differently. We enable manufacturers to scale up production by shouldering risk and providing finance. We work with national governments, civil society, and healthcare providers to get life-saving products to the people that need them. And we focus on impact. From the reduction of illness and deaths from malaria by accelerating access to next-generation mosquito nets, to the prevention of miscarriage and stillbirth through a new dual rapid diagnostic test for HIV and syphilis for pregnant women. We are leveling the playing field. We've reached more than 375 million people in over 90 countries. We are solving failures in health markets to get medical innovations into the hands of the people who need them most. Because we believe fair access lies at the heart of a healthier future.
Great, thank you, Andrew. So can I invite the panel to come up and take chairs, and I'll hand over.
So, good evening, everyone. My name is Helen Rees. I'm extremely new as the chair of the board of MedAccess, but the real chair of the board, who's just retired, is Nigel. Where are you? Ah, there we are. So, thank you all very much for coming, and I do have to acknowledge that England are playing Wales at any moment now. So, for those of you who are not here, send us messages. I'm excited about this panel because I actually think this is a really pertinent conversation. Sometimes panels are good, but this is such an incredibly important topic, and everyone who's in this room knows it, or you wouldn't be here. But the 3 colleagues that I've got here are all coming at this problem from very different perspectives, and I think this is going to make a really very interesting conversation. And, I think just to remind us, building on what Michael's just said, that the hepatitis B vaccine was 20 years in rich countries before it got to the countries where the disease was. And, Gavi came, the Ebola vaccines, and Richard is here from CEPI. Ebola vaccines were sitting on the shelf, not being developed. It was one of the reasons that CEPI was established. And part of my own history, and I'm sure the history of others here, was about antiretrovirals, which we were told would never be affordable in the African region. And anyway, Africans would never be able to follow the instructions and the timing, and it would never happen. And, time and time again, we've had to challenge some of these suppositions in order to get access. And then, of course, COVID, as we've said, COVID vaccines, COVID therapeutics, all of this has just demonstrated yet again the inequity. And then we've seen monkeypox, which is now, probably you've heard from WHO, is going to be called Mpox from now on because of the stigma of monkeypox. And that, again, there were vaccines there, but this was an endemic disease in Central and West Africa. So nothing happened. The vaccines that were there, of course, were used in the latest outbreak by high-income countries. And then you have to actually grapple with that problem, that actually that was where the problem was. But those vaccines were then all used up, yet again. So this toing and froing and how we're going to bridge this gap is incredibly important. So we've got 3 speakers I'm going to introduce very briefly, all, as I say, coming at this problem from somewhat different perspectives, but very interesting perspectives. So Iyer leads the Access to Medicine Foundation, and this holds pharmaceutical companies to account for moving their innovations into the hands of communities and individuals. Prior to this, Jay managed a portfolio of public-private partnerships of $100 million, or euros rather, looking at trying to get, again, pharmaceutical agreements to get pharmaceutical products out there. And Jay is an infectious disease scientist. So we'll be very interested to hear more about Access to Medicine Foundation and the index that you develop. Ebere Okereke is now with the Tony Blair Foundation, the Tony Blair Institute, rather, for Global Change, I should say, and is an expert in global health security and health system strengthening. And one of the things that we've heard very loudly with COVID is, and it's coming out repeatedly, is health system strengthening. And yet, really, we still don't know how to do it. We talk about it, but we're not good at doing it. So I'll be very keen to hear what you have to say on that aspect. But in addition, you had a background in Public Health England and also in vaccine manufacturing development in the African region. So we look forward to hearing that. And Seth Berkley, I think probably everyone has met or knows Seth, who's has been the leader of Gavi for the last 10 years. And having been with Seth on the board, Seth has been an extraordinary leader, has really taken Gavi to another level. So real salute to you, Seth, for that. But I first met Seth with IAVI, the International AIDS Vaccine Initiative, which Seth was the founder of, which really made a huge impact. We're going back to the CEPI ideas, the whole idea of actually development and getting vaccines developed and into the hands of the people. And one thing I will say to all of you here about Seth is that one of his biggest claims to fame, which he does mention from time to time, is that he, in his role in IAVI, he made it to the front page of Time magazine for being one of the world's most eligible bachelors. Yeah, he didn't know I was going to say that. So I think what I'm going to do is invite each of the panelists just to give a few minutes of background from their own perspective, and really sort of reflecting on your own work. So Jay, if you'd like to kick off.
Sure. So thanks again for having me here, Michael and Helen, and the rest of the MedAccess team. So I lead Access to Medicine Foundation. For about 15 years, we have been evaluating the largest pharmaceutical companies on how they improve access to healthcare for their products, and how do they support health systems towards better health coverage overall. And we've been doing this for 15 years, and we use a mixture of data to influence companies. We work with about 134 institutional investors who engage with companies and use the results of our work in stock valuation models and sustainability frameworks. So I was actually in town yesterday. We had a meeting with about 100 investors and it was chaired by Goldman Sachs to kind of walk through the gaps, the current gaps in where the industry needs to prioritize. We also work with governments in helping to shape policy, helping to advise on where investments are critically needed and sustained in order for us to solve this equity gap. And of course, we work directly with companies to try to influence them and motivate them to do much more than what they currently do in terms of access to innovative products. Would you like me to comment a little bit in terms of the results?
Yes.
Okay. Over the past few years, we've seen a constant trend with the pharmaceutical industry. On one hand, the industry has made progress towards global health. More companies take access to medicine seriously. Every single one of the largest 20 companies have an access to medicine strategy with very clear targets. Many companies now have compensation for their CEO directly related to access in 108 low and middle income countries, which obviously upsets them if they don't do well in the ranking because they lose money. At the end of it, I think we've seen many companies also invest in research and development for priority diseases and act and respond when there is a health crisis. However, I think the big however is that the global inequity gap is still huge. I mean, currently the pharmaceutical industry, whenever you have a new drug or a new vaccine on the market, I mean, speak about drugs because I'll leave my colleagues here to speak about vaccines. When you have a vaccine, a drug on the market in the first 5 years of its introduction in the US or Europe, you see that it only reaches about 10% of treatment-eligible patients, even in high-income countries, and less than 1% in emerging markets, nothing in low and middle-income countries. So companies need to plan a lot earlier for access, need to work with governments and partners on the ground to sort of develop these, what does access actually mean at launch, needs to register their products, not only prioritizing rich countries, but around the whole world. And we've seen a marked improvement this year. We've seen actually 6 companies taking this finally seriously, not only just having a framework with policies in place, but demonstrating to the team that in every single project there is a parallel access plan. The coverage of the access plans is still limited to less countries than we would like to see. So for most of the projects, there are about 5 countries in low and middle income countries. No one has cracked the nuts in terms of how to get things to 40, 50 countries at all. And you see a similar pattern also in product access when you have marketed products. Products are still not registered enough in low-income countries. They're still not affordable in many different countries, despite the many different progress made at specific product levels. So there's a lot to do. I think this inequity issue is not new, but it's become so not new that it's so commonplace that we're not seeing the scale of the problem being solved by the pharmaceutical industry. And importantly, I think we're starting to see very few companies actually invested in emerging infectious diseases, despite having an experience with the pandemic right now. So we only have 5 of the largest pharmaceutical companies actually invested in R&D for emerging infectious diseases, leaving a lot of the efforts down to biotech companies who need then lots of resources to get to a level of commercialization and scale. So these are just some of the highlights of our 200 and over page report and analysis that we just did. Yeah.
Thank you. Seth.
So thank you, Michael, for inviting us. And I do want to say that Michael was a hero because he ran the 2011 Gavi replenishment, first replenishment here in London. So we have a long history with Michael, and we'll be talking about the work with MedAccess, which is really important. But let me try to put a slightly different framing than Jay did, because obviously I'm the vaccine guy, and I will talk about vaccines. And if we go back to the history of why Gavi was started, you have these amazing products. They prevent disease. They are the most cost-effective interventions. And if you go back to before there was a kind of a global immunization program, coverage in developing countries was less than 5%. The challenge was that then the basic vaccines began to be available, but new vaccines were coming out, really exciting and powerful vaccines for the largest killers of children. And lo and behold, they were too expensive. There was no desire to get them out. And Gavi was born as a public-private partnership to try to do something about that. And if you fast forward, it's been unbelievably successful. We've immunized more than 1 billion additional children. We've provided vaccines for outbreaks for an additional 1.4 billion people, launched 562 new vaccines, not including COVID, which I'll come to in a second, and have had a dramatic effect. We've seen 16 million lives saved. We've seen 70% reduction in vaccine-preventable diseases, contributing to more than a 50% reduction in under 5 child mortality. So a really extraordinary effect. Now, vaccines don't deliver themselves. This is a dirty secret. So we spend a lot of money on health systems and strengthening immunization systems. And even though Helen's on my board and a dear friend, I will disagree with her on we don't know how to build health systems. We do. What we don't know how to do is connect the building to measures that then can be used as metrics. And this makes it a problem because a lot of people say you spend a lot of money, how are you building health systems? But we do have the real examples of health systems, of delivery of products. One other thing we do is we try to work to change the pricing, do market shaping. And right now, we see somewhere between a 95 and 98% reduction in cost if we go to the highest cost markets for the vaccines that we have in developing countries. And we do that partially from competition, but partially by bringing new manufacturers in and by using things like volume guarantees to move that forward. So that's kind of what Gavi does. And I'll just say a word because Richard Hatchett, who was already called out once, but I'll call him out again, my co-conspirator maybe is the way to say it. And just to say a word about COVID vaccines, because when we were actually in Davos together, and President Trump was down the hall saying, "Oh, there's no disease, there's no problem, it's going to go away by spring, it's nothing." We really thought that's not going to happen, and we need to do something about this. And what we looked at was in the previous pandemic, the vaccines were bought up by wealthy countries, and there were no vaccines for developing countries. And we began the process of putting together COVAX, which became a much larger effort. And it was very interesting because if I fast forward, it's remarkable what has happened. Countries have delivered developing countries, more than 4 billion doses of vaccine. We've seen now coverage rates for full vaccination in the AMC 92 countries is at 52%. This compares to 63% globally, so not quite equitable, but much further than ever before. We had our first vaccines 39 days in developing countries after the first injection here in the UK, something that used to take years, if not a decade. But that's the successful side of the story. The unsuccessful side of the story is what was referred to by Michael, and that is, early on, wealthy countries via vaccine nationalism held their products, closed their borders, didn't provide supplies. We had export bans that affected the supply for developing countries, and we've ended up with really big disparities. And so one of the challenges that we'll want to talk about in this conversation are what some of the things we can do for the future, because I think it's quite clear that this behavior will continue and will be the same in the next pandemic, which, by the way, is not if there's another pandemic, it's just when, because it's evolutionarily certain we'll continue to have pandemics. So I think we can have a very interesting conversation here.
So, Mary, I would like you also, as you introduce your sort of background, to talk about access and global health security and how those two also hang together.
Thank you, and thank you, Michael, for inviting me to join this panel discussion. It's an honor to be here. I'm, like Helen said, I'm just a public health physician. In global health is first and foremost about equity, and so the lens through which I look at what we're discussing here and what we're trying to do is around equity. How do we ensure that the resources that are produced globally to improve health are equitably accessible to everybody? And I think that much as things are improving now, it has not been a success story. But I wanted to step back a little bit. My background initially was an infectious disease clinician, and I moved into public health, particularly communicable disease control, because I wanted to move upstream. I wanted to work on prevention. And like Seth, I share the commitment as to the importance of prevention approach to health and vaccines in particular. And that was what led me into my work with Public Health England and into Global Health, where I used to lead a program that was primarily around how do we strengthen the public health systems part of the health system to be better prepared for pandemics and to response. And Nigeria CDC, which is now often reflected as one of the models of good practice, and Africa CDC is more recent organization. Some of the organizations that we worked with to support them to be better able to use the resources that they had. But I wanted to step back a little bit and look at the title of this evening, which was working in volatile times. And most of my work is in Africa. So from an African perspective, these are normal times for us. Volatile times are our norm. As has already been touched on, there have been innovative products to improve health for a long time, which we've not had access to. We've had, political instability is not new. Geopolitical dynamics, we've been the football field for the global geopolitics for as long as history goes back. So nothing here is new. The only difference is that all of a sudden the rest of the world were in those volatile times with us. So we have experience of constantly struggling for access to things that others take for granted, like Michael referred to. So for us, what have we learned in this recent pandemic? What have been the challenges? I'd like to start by, first of all, saying what actually was good. And I touched on institutions like Nigeria CDC and Africa CDC. And what we've been trying to achieve through those sort of organizations to improve how we use the resources we have. And a critical aspect of that is better coordination. So if you ask me what was the one thing that I'd say this was a positive that came out of the pandemic, it was Africa CDC stepping into that coordination space to actually optimize the impact of the resources we had. But the same story that was told 10 years ago about access to HIV drugs was told and is still being told today about COVID. But one of the critical things I think we also need to recognize was the absence of the voice of low-income countries in the conversations when we're designing these solutions in preparation for the COVID pandemic. If you had asked me, and Seth, you could have, at the beginning when COVAX was being designed, I would have put money on the fact that what happened would have happened, because that political will was not there. And the plan for COVAX did rely on those more economically resourced countries committing and doing what they said they would do. They didn't. And we agree that if it happens again, or when it happens again, unless something changes, that will be the norm. Countries will pull up the drawbridge and become very me first and others afterwards. But we also have a responsibility, and I speak mostly from my experiences, mostly on the African continent. We need to hold our own governments to account. We need to actually start to challenge those governments by building the recognition amongst the citizenry, the electorate, that their governments have a right to health, and therefore their governments should be held accountable. So that we have this opportunity now, because of the focus of attention, I tend to call it the pandemic dividend. There is a political focus on health now, recognizing that it isn't a nice to have an expenditure, but a necessary investment if you're seriously committed to economic growth and to development. You have got to focus on health. And so I think there is now a window of opportunity for a healthy conversation from the innovators, the funders of new research, and African public health institutions and political leadership to start to think again. That means we need to be in the room. We need to be part of the conversations from the beginning. We need to be part of designing the solutions so that we end up with products that are easier to deliver, than vaccines that need -80 freezers, which are always going to be challenging with the best will in the world. So it's about actually stepping back and saying, where should the conversation start and who's in the room when we start those conversations? And then we have to hold our own authorities, our own leaders to account to say, we need to put the little resources we have into that solution. And we need to coordinate better what resources we have. We have too many vertical programs. And one of the, I was reviewing a paper submitted for a journal that I'm an editor for, and it was talking about the model of using the HIV architecture to deliver COVID vaccines, and that's something to be recommended. My argument actually is no. The HIV architecture exists because the health system itself hasn't been developed. And what we need to look at is, how do we move what is a multiple vertical programs into a much more sustainable horizontal health system that will serve the endemic diseases, the new and emerging infections, whether they're non-communicable diseases, because we're also going through the epidemiological transition. So it's not just malaria, HIV, TB. We're beginning to deal with cardiovascular disease and so on. So we need to step back and look at how do we move some of these multiple vertical programs into the universal health coverage and focusing on primary health care. And that's where, when we start looking at health system strengthening, it's around avoiding some of those holes between the parallel programs, tying them better together, and then making them much more able to deal with whatever the situation is, whether it's an endemic disease, infectious disease, an outbreak, a pandemic, or neglected tropical disease. And quite frankly, neglected tropical diseases are just diseases that those with funds to invest in have lost interest in. And if we continue to carry on this argument, COVID might end up in that pile as well.
So let me just pick up on what you've just said, and I'm going to put this back to Seth, because I think you were also asking some questions about COVAX. And I think the question to Seth would be, with the kind of wisdom of retrospect, what are the lessons learned? Because COVAX is the only model, really, that has gone global and that has attempted to get the vaccines out. What are the lessons learned, hearing the criticism of the lack of engagement of low middle-income countries? Do you want to just comment on that?
Yeah, I mean, we can look at the glass half full or the glass half empty. Immunization is the most widely distributed health intervention in the world, including in Africa, but I tend to think of it as more global. And the important issue about that is, obviously, it's the most cost-effective intervention. For every dollar you invest, you get a $21 return. If you account for the value of that health, it goes to $54. So there's nothing like that. And the challenge is that, of course, there are zero-dose communities that get no vaccines, and there are people that kind of drop out of the system. So how do we make that truly universal? And I agree with you. This is a requirement. It should be a responsibility of every government in the world. And one of the challenges in Africa has been the spend on primary health care, the spend, as you say, resources are limited, but making sure that they get used for the most, the allocative efficiency of going to the places that are really best. And there has been a challenge, and I must say that conversation's been very healthy recently about the responsibility of governments to increase their domestic spend in addition to having outside spend. So I think that's one set of issues. But in terms of this question of conversation, of who's in the conversation, the Gavi board is made up of African governments, of Asian governments, of CSOs, you know this well because you're there, and that was the responsible body. There was a big debate that went on, how wide and how big do we bring in the groups that want to be engaged, and how much do we want to try to move as quickly as we can to move forward. The delays were in 2021. As of the end of 2021, there actually have been enough vaccines for any country to get access to. The challenge has been getting those into the health systems and moving those out, particularly because we don't have programs for the elderly. We don't have programs for people of high risk. And so this has been the adaptation of the system. And that's why, from my perspective, it's been remarkable how much has been accomplished in a very short time period. And I guess the question really for us is, if we want to change this going forward, do we need to bite the bullet globally and create a system that is across all age groups? Because that's something that doesn't exist right now. There aren't programs for the elderly in general. It includes the chronic diseases you talked about, but that has been something that donors have not particularly wanted to do, and countries haven't necessarily prioritized. And so if we look at the statistics for the AMC 92 countries, we're at 81% vaccination for healthcare workers. That compares to 70% in high-income countries. So we're doing better than high-income countries. But for the elderly, 66%, as opposed to about 85% in high-income countries. So, and I think that shows the challenges of those systems not being available. And let me just make one more point, because I think this is an important part of the discussion. It's something I hope that Michael will invest in going forward, and that is the importance of trying to expand the base of manufacturing. So when Gavi was first started, there were 5 manufacturers. 4 of the 5 were in developed countries. Today, without COVID, there are 18 manufacturers, of which the vast majority are in developing countries, but only 1 is on the African continent. And so one of the challenges is, if you could build manufacturing capacity across Africa, that doesn't guarantee that you'll have more access during a pandemic, but it increases the chance that you'll have some manufacturers that are going to be able to provide vaccines for the large number of countries that are there. So right now there's 30-odd initiatives that are going on to build vaccines. Most of them are COVID vaccines, which frankly aren't needed right now given the global supply for COVID vaccines. And so one of the challenges is, how does one create a system, an ecosystem for production of vaccines that is sustainable, that meets the needs not only of, for example, African countries, but more globally, and then having the capacity to deal with routine diseases, but also some of the regional diseases that are important, diseases that CEPI's working on, like Ebola or Lassa fever or yellow fever or cholera or others that may be regional, and then also the capability to move in the case of a pandemic. And so we've been working to try to create a new ecosystem for that, and the type of work to help the manufacturers figure out what might be the products, how to do that work, and then of course one of the critical issues is going to be, how do you create that marketplace without destroying the existing marketplace, which is critical because it provides low-cost vaccines that is supplying countries not only when they're being supported by external groups, but as they graduate from Gavi support. The only reason countries can continue to provide vaccines is because the vaccines are at low cost and high quality, and that's something that we really have to continue to work on.
So I'm just going to come back to Jay, and then I'm going to come back to you as well. But I just want to ask you on this point, with your access to medicines index and your knowledge of the thinking of pharmaceutical companies, I mean, do you see a change, would you see in the future a change in behavior? And one of the difficulties for COVAX was actually getting some of the major manufacturers to come to the party early on, which was one of the big delays. Yeah. So from what you've learned, for the companies that are not actually coming to the party, that are not scoring well on the index, and what we've learned from COVAX, what do you think are the biggest issues that are preventing companies from doing this? And how, for example, civil society, academics, global organizations, how do we exert pressure? How do we build that momentum?
It's the age-old question at the end of it, isn't it? I mean, at the end, you want to, you're not going to see companies naturally coming by and peddling their wares and say, let us help to expand into the key markets. I mean, they'll be interested in large volume markets. And a few have put some strategic focus in countries where there's universal health coverage. Government is putting a lot of investments in across the board vaccines or medicines. So Rwanda, South Africa to some degree, Kenya, you see a lot of activity with the pharmaceutical industry. Again, vertical programs, lots of capacity building, a lot of investments going in, only very few products really following at the same point. So I think companies now are starting to recognize, I'll say innovators and producers are starting to recognize that we need better regional availability of products. But they don't have a system to make that happen, which is why the systems that we're talking about here is something as a public good we have to support. Many governments will have to get together, civil society will have to get together to say, we need to have a better regional availability of key commodities, vaccines, basic essential medicines, and we can't rely on the goodwill, or we can't wait and see border closures. I think a few months ago, we also had a workshop on just the urgency of how raw materials are so closely connected. I mean, I'm not sure that everyone understands this, but even one of the COVID vaccines has about 19 components, about 200 components coming from 19 different countries. So when you think about the dependency that the pharmaceutical industry themselves have built, and the cost associated with that, the resilience or the lack of resilience associated with that, you can see how fragile the system is. So when you talk about volatile times, we see volatility in terms of multiple crises hitting us as a society. We see volatility in terms of availability of financing. But I think we have learned a lot in the last decade in terms of which systems work. Which systems do we need to continue investing in and build on? The kind of systems that we were just speaking about here is going to change the world. And then you would see, naturally, the pharmaceutical industry, the vaccine industry, responding to that. But it's not going to be driven by the pharmaceutical industry and the vaccine industry from the Northern Hemisphere. It's going to be driven by a wider pool of manufacturers getting involved. I think we already have those examples when you're thinking about childhood vaccines with biological E, Bharat Biotech and Shanta Biotech. Many biotech companies, really getting a decent business into this space. And if we can start doing that in a more coherent, structured manner, I think we'll solve a lot of the world's problems.
Can I just challenge on one point with that, which is interesting? You started out by saying the large companies. The large companies didn't, by and large, come out with COVID vaccines. If you look at Moderna was a biotech startup, BioNTech was a startup. Yes, J&J was there. Novavax was a startup. I mean, the point is that this is not big company R&D. And one of the questions is that used to be the model, but now we're moving to a new model, which is acquisition from biotech, from academia, et cetera. And if that is going to be the case, maybe that democratizes it a little bit more than the old model, which was you had to have a $20 billion R&D budget every year, massive laboratories, et cetera, and that may change the point. And I forgot one point I wanted to make, because I know you're going to want to respond on this, but I'm the last person that wants to have minus 80 degrees in difficult places. But the challenge is that's what countries wanted. We had vaccines that were stable at room temperature, that were as good as, maybe even better than the mRNA vaccines, but the demand was, we want those same vaccines that those wealthy countries are using. And our belief, of course, is to try to respond to country needs. So if they wanted it, we tried our hardest to make it. But of course, it's silly to be trying to get minus 80 vaccines out to the periphery of countries, but we did that because that's what they asked for.
Yeah, but we need to recognize that we live in a global ecosystem, and this is the first social media pandemic. So the decisions made by the FDA in the US are heard and listened to by the person in Zambia who basically thinks, if that's the position for the US, why should I get something different? So there is the additional complexity of this new global village that we're operating in, where you can't, especially if you don't have regional architecture that is driving the conversation and the priorities in a region, where a global voice and there's an expectation of a global product and a single approach for the globe, which creates additional challenges for us. I accept that. But I wanted to come back to your comment about what we do around vaccine manufacturing, and I'm conscious we're talking about vaccine manufacturing particularly, but it is relevant to the same issues that apply to other essential medical products. And currently, I had the privilege in the first year of working, co-leading the Partnership for Africa Vaccine Manufacturing, which is now in the process of implementing its framework for action. And its whole purpose was saying, how do we create the ecosystem to make vaccine manufacturing viable and attractive here? So we're not suggesting that companies shouldn't make a profit. That isn't the point. But there's a recognition that to build up the industry, there does need to be some investment, but we need to make it easier for their industry to be attracted to invest in the continent. So there's some concepts. We need to recognize that the African continent is probably the biggest growth market for vaccines. We don't have full penetration for existing products, and a lot of the markets for new products are completely, very few countries are doing flu vaccination, HPV vaccination, for example, and as the population is still growing far faster than any other regions of the globe, commercially, it should be attractive. So what the PAVM has been trying to do is, so how do we make it attractive? We looked at, okay, we need to strengthen the regulatory architecture for the continent so that they're actually able to support the industry, support manufacturers who venture through. We need to look at how we look at trade policies to make it easier for products to move from country to country, for the reagents and all the products that go into producing vaccines or whatever medicines to be brought in and to move across the continent. We need to look at the actual architecture, the infrastructure for the factory where you're going to build the vaccine. We need to invest in R&D. We need to start to think about African-informed and influenced R&D, working with CEPI, but they should be. We have universities such as yours, Helen, on the continent who are already beginning to do R&D. We need to make it easier for them. We need to develop the workforce. So some of these initiatives have already started to yield dividend. We've gone from last year, we had only 2 African national regulatory authorities that met the WHO maturity level 3. We're now at 5. We expect that before the end of mid next year, we'll be looking at 7, 8. And the aim will be to continue to make it easier for industry to partner with the continent to start to build that manufacturing capacity. And it isn't just for Africa. It's not, although the focus is we've through the PAVM, we came up with a strategy about what vaccines should we be prioritizing for our own needs, but very much a recognition that it's actually part of the health security architecture for the globe. The one thing that we found and we experienced with COVID and COVAX, for example, was we put all our eggs in a very small number of baskets. And so under those circumstances, you know, the situation changed in India and Serum Institute couldn't supply. We had not enough manufacturing capacity. And there is a constant dilemma to get that balance between, you know, peacetime manufacturing capacity that is reasonable, so it makes sense financially, but has the opportunity to scale up. And currently it's too skewed where it is. It's in too few places. So part of what PAVM is trying to achieve is not just about increasing capacity of our own manufacturing for what we need, but building into that global architecture that is part of that health system strengthening. And I stress that pharmaceutical companies are part of the health system. There may be private businesses, they may have a primary focus on delivering profit for their shareholders, but they are part of the health system. And quite frankly, no matter how you look at it, they have not held up their end of the bargain as well as we would like to see. It's improving, but we need to do more.
Yeah. So I'm going to come back to Jay, because I want to ask all of you, because clearly MedAccess is looking at innovative financing. Gavi has done this with very good effect. So I want to ask all of you, and starting with Jay, with you, with your experience, what is the role of thinking of new ways of financing? Because, you know, in the context of, you know, even startup companies making billionaires in this context. So what is the role of innovative financing, and how do we build on the sort of successes of Gavi, the 5-year success of MedAccess? What should we be looking at to say, how do we actually support companies to do what you're saying, to actually get the products and get the products out to the communities where they're needed? So let me start.
So I think on one hand, it is important that people like us and a few others are, you know, continuing the push for getting innovations, making sure R&D is actually happening.
Yes.
In partnership with not only researchers who articulate just a need, but specifically what is the solution they're looking out for. So in the design of the product, in the deployment, the design of the delivery of the product, the design of the deployment of the product itself, and the design of the services around the particular product. I think that is hugely underestimated. And we cannot forget that a lot of innovation is coming from the biotech industry, not only for vaccines, but and they are very, very far removed from the communities. They're very far removed from national policies. I think in drug-resistant infections and AMR, there has been quite a strong connection, and the Wellcome Trust has actually put a very strong voice in asking for clear policies on access if you have a product that is being developed also for biotech companies. So that's I think important. But beyond R&D, because you do need the products eventually to get out there, you need to find ways to solve that equity gap. So most companies do not enter particular markets because there's no market or there's no availability of financing. So they need a system that bridges that gap temporarily or long term. And this is where innovative financing comes in. So in the last couple of years, we've seen, in the foundation, a large number of impact investments. We've seen organizations like MedAccess coming forward with ideas on volume guarantees, choosing the right portfolio, making sure that those volume guarantees are available for the right products. It takes time, but you can see the immediate difference that it makes. And moving on to also procurement guarantees, I think it's the next big challenge, because I think a lot of countries are interested in purchasing. They just do not have the financing available at the right time. So innovators, so producers basically will be like, okay, well, I'm just going to go to another city. I'm just going to go to whoever is able to pay first. Not only who's going to pay more, but who's going to pay first. And the only way to solve that is by making sure that innovative financing comes in at the right time for the right groups available. And I think that small volume markets are struggling the most. I mean, we've seen no interventions in 15 years of analyzing this index work. I've seen no interventions in island nations, small states. I've seen nothing happening for low volume products. So we do need to continue innovating on innovative financing at the end of it. Now, there's a new trend that's also emerging now with industry, and it also tells you what's happening in the world, that there's a much more interest in supply chain stockpiling, or at least having some level of buffer stock available to meet demand changes. There's no financing mechanism to offset that for companies. So only a few companies are doing that at the moment. There's a system in vaccines, but there's no system in medicines right now. And so what's going to happen is eventually companies are just not going to have buffer stock available, not going to meet the demand. So innovative financing, absolutely important, and is there to stay.
So if I can, I mean, here's an example of where it didn't work. I mean, we had a company in South Africa that shifted its line to make vaccines, went ahead and got the ability to manufacture a vaccine, but had not ahead of time figured out where the market was going to be, and at the end there were no buyers for the product. That was a very, very disturbing thing for that company who was trying to do something and had an opportunity to do it. So it's really important to have these types of demand guarantees and to understand the marketplace, because at the end, that's what is going to really make a difference going forward. Now, when a new company, doesn't matter where it is in the world, produces its first vaccine, it is really expensive because you got to amortize the cost of all into that. And of course, vaccines are a volume business. When you get to very large volumes, the costs come down. And so one of the challenges then is, how does one set up a situation that can allow those companies to be competitive, to come into the marketplace, to be able to sell their products when there's other sellers, but also not to have the other sellers say, oh, well, if this is going to be expensive here, I'm going to jack my price up because that's going to have an effect across the market. So this is a very complicated but can be done set of innovative financing instruments that can look how you subsidize for a period of time the manufacturer to get to that scaled up point that then those products can be competitive and operate in a global marketplace. And so that's the type of instruments that we're going to need to be thinking about going forward.
Yeah, and on the African continent, some of those conversations, beginning with the Africa Development Bank, for example, is actually looking at setting up a fund specifically around pharmaceutical products beyond vaccines, and with that aim of subsidizing startups so that they can actually start to build up the resource to the stage where they can then run on their own. And that's really important. Again, I do stress that vaccines are a public good. So there is a political responsibility for governments to also contribute to these financing solutions to make the vaccines and other medical products accessible. And we need to remember that we're not just talking about vaccines and pills, and we're thinking about things like, oxygens. some of the things that we take for granted. We're talking about diagnostics and there's a lot of conversation about new technology, making the time from, if we're building on CEPI's 100-day mission, go from start to having a product in a short period, which is wonderful. But like I said to Richard, it's no good if you produce a vaccine in 100 days and it's going to take another 750 days before I can deliver it. So we also need to be looking not just at the products themselves, but the mechanisms for getting it into arms, because it's no good if it's just a vaccine sitting on shelves. And a lot of the conversation now is saying, okay, there's enough COVID vaccine, but we're not getting it to people. And I'm thinking, but we knew this problem existed before. We didn't actually plan early enough for how we're actually going to get vaccines from production into people's arms. And the longer it takes, the less likely there is to retain that we get vaccine apathy now. People thinking, well, we've been waiting for so many years, why bother? So in planning for the next pandemic, and naturally not waiting for the next pandemic, because we have the ongoing pandemics of TB is still, it may be endemic, but it is still killing people at pandemic rates in certain parts of the world. We still have a lot of diseases for which we have some products or some products that are nearly ready. We need to start now to think not just about the manufacture of the pharmaceutical product, but how do we engage with governments, with philanthropists, with investors, with citizens to ensure that we think through the whole pathway, from producing the vaccine to getting it into people's arms, and addressing the issue of how do we create demand for what is already available, so that we can actually provide the assurance for the manufacturers to produce that, because they say there will be a market for you. That market does require that governments have immunization strategies and policies that will say we are going to have a hepatitis B vaccination program. We're going to have an HPV vaccine program, so the manufacturers can start to see that there is a genuine market that is accessible there, not just a theoretical one. So it's a very complex ecosystem, like you said, and it's one that does require coordination and collaboration across the space, from private, from public, political, scientific, and financiers, as well as the manufacturers to solve. But we've all got to be talking to each other. We can't just shrug and say it's too difficult.
So I think, just to pick up on that last point, and then I'm going to come back to you all for a 30-second, what are your biggest takeaway points? But just to pick up on your last point, this pipeline, it's not, when people talk about manufacturing, it's not just putting up a factory. It is the easy part. It is the entire R&D effort.
Yeah.
It is the regulatory effort. And so you can't just say, well, we'll just improve the regulatory. You need regulatory science. You need R&D. You need scientists. And you need to make the environment attractive that actually you retain your scientists. I'm speaking as someone who heads a large research institute. You've got to be able to retain people in an environment that's very tough. But that's where the diseases are. And that's where you're going to develop some of the therapeutics and the vaccines and the diagnostics. And we need to. So this is a continuum. The other thing I'll just highlight, which I think is quite interesting and topical on this matter, is a lot of you have sort of talked about, the continuum and the implementation side and the health system side. One of the tools that WHO is just in the process, has just developed, is called the Evidence Considerations for Vaccine Policy, but it would be the same for therapeutics, which actually starts to ask the questions beyond what is what's called the target product profile of a product, which says, it should be single dose, it should be at this temperature. It asks all the other questions. It says, who do I want to give it to, and how do I want to get it there, and what are the kind of regulatory? It asks all those questions that if we don't ask them early on, we suddenly scratch our heads, like the malaria vaccine, and say, oh, and now we have this vaccine, and it's not the childhood vaccination program, So how do we do it? So I think people are starting to think about that continuum as well, which I think is extremely important. But now I'm going to come back to each of you for a summary, few points, no more than 2. I just made that up. So to say, what do you think are the most important things from your perspectives?
Yeah. Oh, I start. All right. Okay. Well, I think at the end of it, you have to put the needs of the people first, right? And it's not just about saying that, but you have to, let's face it, volatile times are always going to be in front of us. we feel as if we're in the midst of one of the worst volatile times at this moment, but it's always going to be in the midst of in front of us. And I do think that we have to have, as a society, we need to make smarter decisions on what is working and continue investing in that, and be ready to make changes in things that are not working. At the end of it, you can't rely on the goodwill of a couple of pharmaceutical companies. You can't rely on the goodwill of a relationship that you have with a few organizations. You need to build stronger systems in place, and that takes dedication. That takes people sticking to certain roles and staying in global health. That also means speaking to a wider audience. As I said, biotech companies are not part of the conversation. Communities are not part of the innovative conversation right now. We need to have that wider conversation and not stop at the conversation, but really put our investments there. Yeah.
So I think the the issue is really about political commitment. And when we started, we said everybody's not safe unless everybody's safe. And I don't think people all said it because it was politically correct to say it, but I don't think they believed it. I don't think they believed it until Delta, what came in India, and they saw the funeral pyres, and all of a sudden that strain spread across the world within a month. And then when Omicron occurred, it spread across the world again. But we haven't really fully incorporated because we've lived in the past with, panic, neglect, and just look at what's happened. You have in your sewage here in London polio virus, and when they went out to provide polio vaccine, the uptake has been 25%. Do people believe it? And this is the point that has to happen is we've got to get political leaders to understand we are in the era of pandemics. It's evolutionarily certain. They're increasing. We're going to see more and more of them. And so the challenge then is in peacetime. How do we build those systems? How do we make sure that we have the financing available? Richard and I were just talking. It's a disgrace. Ebola Sudan appears in Uganda. There's 6 vaccines and others in basic research. None of them are vialed and ready to go for a clinical trial. Why is that? Well, because you didn't know when the outbreak's going to occur, and you're going to waste a couple of $1 million if you produce the vaccines and it's 2 years later and you have to throw them out and reproduce it. In the big picture of the $12 trillion we spent on COVID, what's a couple of $1 million? But the challenge is then getting somebody to do it. So how do we get to this new mindset, which I hate to use a military analogy, but in the military, they don't care about wasting $2 million. They are constantly redoing things and doing war games and trying things and having redundancy. And in global health, we're on a shoestring all the time. He didn't get his full funding, for his in London here, his CEPI replenishment, nor did IAVI. So this is something we have to change the political mindset of.
Yeah, absolutely. And just following the same thing, it's about equity. We need to actually commit. First of all, we need to acknowledge and recognize that everybody's entitled to the best health options that they can get. And there should be equitable access to the resources we have, whether it's new for innovative products or existing products. That has got to be something we have to keep pushing political leadership, pharmaceutical industry to accept. We then need to have an always-on system. Like you said, the military are always ready. They're running war games all the time. Like they waste a few million every now and then exercising and playing with their new toys.
A few billion.
And a billion, more like. So I don't think we actually need to spend anywhere near as much as the military does. But if we actually start to invest in the infrastructure that creates and improves access to the everyday, to the solutions for everyday problems, the endemic diseases, the non-communicable diseases, we're much more likely to be ready for the next pandemic, rather than what we will, if things don't change now, what we will see is that same rabbit caught in headlights response when the next coronavirus, and it's a good chance it could be a coronavirus, starts to challenge our system. So we really have got to collectively see ourselves as a single, this isn't about nations, it's a real global response. But we also need to regionalize some of that capacity to respond so that we can focus on the priorities in certain regions, the needs in certain regions, which are slightly different from place to place. We talked about small islands, and in addition to sort of investment in essential medicines, they're facing the unique challenge now of climate change. It's not a future problem for them. And climate change is going to contribute to more pandemics as well. So we have got to start to look at it through the lens of equity. That's the one thing we need to do.
So I think just to wind up this, it's been a fantastic discussion. Thank you very, very much. And to wind it up, I think we talk about the R&D pipeline, and we go from the lab to the preclinical to we talk about that. But the pipeline for around access to health products is a pipeline that has many other parts in it. And we're here talking about innovative financing. That is part of this pipeline. You mentioned regulatory. We talked about implementation science, health system strengthening. This is the pipeline. And those are some of the huge pieces that I think we have omitted to focus on. Plus, the reality of the dialogue, as you have said, and you have said as well, with the private sector, all three of you. The private sector is, in my sort of student days and in my good old lefty student days, the private sector were the bad guys. Yeah. The reality is the private sector is part of this continuum, and this has to be an engagement that becomes a win-win for all parties. So I think with that, I would like to say a warm thank you to this excellent panel and panelists. Thank you very much. And you're all invited to go upstairs for drinks and canapes. There is no big screen with the soccer on. I'm sorry, everyone. But there is a drink and an upstairs. But I think before we go, I'd like to say congratulations to Michael and to MedAccess. 5 years with huge achievements and growing, and the board and the funding agency, the belief that the BII has had in this project, which was a brave project, and it's evolving. I think we all recognize that. And it's evolving, going back to the title of this, in very volatile times. The financing we're all experiencing is going to be a challenge, and we're all going to have to focus on it. But part of this is a civil society dialogue, so that we all learn more and we can all advocate more for the importance of supporting innovation. Thank you very much.